Yeah, people are slowly filtering in. We'll give them another maybe minute or so. All right. Well, that was my few minutes. So why don't we rock and roll? Good evening, everyone, and welcome to our second session of our two-part series hosted by Fujifilm and Vantage. My name is Jeff Mosko. I'm a gastroenterologist at St. Michael's Hospital in Toronto. You may recognize me from the last session where I spoke about it's my pleasure to host tonight's or moderate tonight's session. We have two excellent speakers, which I will introduce separately, who are going to talk about their experiences with the Fuji Eluxeo system and how it has improved outcomes in endoscopy for them. Again, thank you so much to both Vantage and Fuji for putting this together. We appreciate this. And if you guys have any questions, please feel free to write it into the chat. I will be monitoring the chat and we'll bring up any questions that you have. So it is really my pleasure to introduce the first speaker, Dr. Ian Bookman. I've known Ian now a long time. He is at St. Joseph's Hospital, which is now our sister hospital, or we're your sister hospital. It's hard to know. He's head of gastroenterology there and the medical director of Kensington Screening Clinic. He's an adjunct assistant professor at the university, and he has been awarded the Best Clinical Teacher Award. He stole that from me, I guess. And is also the president of the Ontario Association of Clinic Endoscopists. So a very accomplished guy, and I'm told a much better colonoscopist than I am. So Ian, thanks for being here and wowing us with your talk tonight.
Thank you very much, Jeff. I think we've had some endoscopy nurses train at St. Mike's, so I always make sure to tell them to mention how much better I am than you. When
yeah, they do.
I'm glad to hear that worked out.
Yeah.
My talk today is going to be on LCI and BLI for improving outcomes in endoscopy. Can you see my screen okay?
Yep.
Okay. So this is a short talk. I hope to just briefly explain what the different light modes are and how they work, show some examples comparing the different light modes, and then go over some of the evidence on how it impacts polyp detection rates in endoscopy. So this is just to give a very brief background. On the right is, the traditional bulb or light sources. We would use the incandescent bulb, which had a simple wire filament that would heat up to the point where it would glow, and extremely inefficient, would burn out and need to be replaced. The brightness would gradually dim. So these have gradually been replaced with the LED lights similar to our homes. They've been replaced in the endoscopy light sources. So LED stands for light emitting diode, and a diode simply is a material. It's called a semiconductor because it only partially conducts the electricity. It has a bunch of electrons on one side and none on the other. So when the electricity hits the diode, the electron jumps from the electron full side to the electron empty side, and it releases energy in the form of photons, which we see as light, especially when it's within the wavelength spectrum of our human visibility. And we can control the color by choosing different materials to use as the diode. So for example, if you have an aluminum diode, it'll give off red light. And if you have gallium, it'll give off green light, and so forth. And if you combine them in similar amounts, red, green, and blue, you see white light. And you can even combine red, green, and blue LEDs into a single multi-chip LED device, and you can control the relative intensities of the different colors to essentially produce millions of colors. So with that, Fujifilm chose 3 light modes to present all these different variations. And they are the white light imaging, which is on the left, the linked color imaging, or LCI, which is in the middle. And you can see it has a lot more blue-violet and not as much blue, and slightly more green. And then on the right is the BLI mode, which is predominantly blue-violet. And the reasoning behind which light modes to present was based on which wavelengths were best absorbed and reflected off hemoglobin, which could most pronounce the superficial vessels that we see in the neoplastic lesions. So the linked color imaging, or LCI, essentially takes wavelengths even beyond our visibility spectrum, and then processes them in a way that they can put all of the reds together so that we can see it more than usual. So the reds in a lesion become more red, and the white in the background and on the mucus layer become more white. So a subtle lesion pops a lot easier, and that's why we sometimes call the LCI mode our detection mode. So we will enter the colon using white light and then withdraw in LCI, so all these lesions pop out and are easier to identify. And blue light imaging is interesting because the blue-violet light reflects off the most intricate vessels in the very superficial mucus layers, and that's how we can get some extremely detailed characterizations of the pit patterns and the microvasculature, which allows us to use all the various types of classifications to predict the histology of the lesions. So these are just some examples of lesions in different light modes. So on the left, the white light, there's a 5mm polyp in the transverse colon that you might have to strain to try to see. And in the BLI mode, it's extremely obvious. It's almost like a coloring book, how easily the borders can be identified, and then on retrospect, you can somewhat appreciate the lesion in white light. And with optical magnification, you get extremely detailed views of the crypt pattern. If you're so inclined to use a system such as the Kudo classification, you can look at it and see that this is a type 3S with the very smaller than usual pit patterns, and therefore predictive of a tubular adenoma. In this adenomatous lesion, you can see it looks like a fairly pale, bland polyp on white light. When you switch to LCI, you can start to appreciate some of the vessels, and this is a bit too close up, but normally you would see that it pops out quite differently from the background. And then BLI, again, you see this nice regular pattern, which would be a nice type 2, which is my favorite classification because it's the most simple. Like myself, it's either type 1, which is close to normal, type 2, which is obviously different, or type 3, which is obviously wrong, where there's lacking of the pattern or vessels in part of the lesion. And here's one that's comparing all 3 light modes. So this is an adenoma that you can see looks fairly benign on white light, not that impressive. When you switch to LCI, you can see the nice type 2 pattern in the periphery, and it distinguishes itself a bit more easily from the border. And you can see in both the LCI and the BLI mode that there's a loss of the pit pattern and vasculature in the middle, which already makes you start to suspect. This would be consistent with nice type 3 in the middle, so suspicious for dysplasia, but there's no pitting, so this could be taken out with a snare, and the pathology here is consistent with a high-grade dysplasia. And I thought this was a nice example because this looks like a fairly benign either hyperplastic, or if you're in the right colon, sessile serrated polyp. But when you switch to BLI, suddenly you can see that there's quite irregularity of the crypt pattern and vasculature, suggesting that this in fact may have some dysplasia. And when it was excised, indeed, the histology showed an adenoma with low-grade dysplasia. And then lastly, this is a transverse colon sessile polyp that looks fairly bland, similar color to the background in the white light. When you switch to LCI, the white becomes more white, so you can see the border a lot more clearly. And then BLI magnification shows a pattern that clearly is not hyperplastic. And after this was excised, the histology was consistent with a sessile serrated polyp. So it's quite fun and obvious when you're doing this to identify the lesions. For example, this is white light and LCI. Perhaps very easy to see is C versus D. Often you'll see the lesion on LCI and then have to go back to try to find it in white light. There's been over 160 studies in the literature now comparing the different light modes throughout the GI tract, and over 35 of them are in the colon alone. So I obviously had to pick a couple to highlight. So this was a very nicely designed study out of China, published in Gastrointestinal Endoscopy in 2017, where they randomized patients to undergo tandem colonoscopy. So the first endoscopist would scope the patient in LCI. They would identify where all the polyps were. There was an independent observer in the room who would record it. The endoscopist would withdraw, not remove any polyps, leave the room, and then a second endoscopist would enter the room, perform the same colonoscopy on white light, and then remove all the polyps. And if they missed a lesion, then the independent observer would point it out to ensure it was missed, but not count it as one identified by the second endoscopist. And then the reverse was done with white light followed by LCI. And from this study, the main numbers to look at are here, which shows that 83 lesions were detected by LCI, but not white light, versus 29 lesions detected by white light, but not LCI. So it was a statistically significant difference. Adenomas, there were more detected on LCI only than white light, but it was not statistically significant. And when you look at the per patient analysis, there was more polyps identified on LCI only versus white light, 27 versus 4, and more adenomas, 13 versus 1. So smaller numbers, but still statistically significant. And in this table on the right, the main thing to pay attention to is that the LCI colon numbers are, for the most part, generally always higher than the white light only numbers, most notably in the smaller lesions and in the flatter lesions, 64 versus 19. So the authors concluded that LCI increased polyp detection rates, identified more patients with polyps, and increased the per patient adenoma detection rate. And then this was a nice study out of Italy, published in Endoscopy in 2018. And this particularly looked at a miss rate in the right colon, which is something we're always concerned about. It was an identical format, but even more patients, 600 that were randomized to the two groups. And here you want to focus on the second column, which shows that 34 adenomas were found on LCI that were missed on white light versus 13 on white light that were missed with LCI. So the miss rate went from 31% down to 12%. So the authors concluded that LCI reduced the right colon adenoma miss rate by close to 19%. This light mode has been so impressive that some physicians, Dr. Bishops from Leuven, Belgium, and Dr. Hassan from Italy, have created their own classification using the BLI mode that combines characteristics from all of the other ones like Kudo and JNet and NICE into one simple pattern that they felt was so clear that they could show high concordance amongst different endoscopists. And in fact, they published a study showing that in BLI mode, most of the endoscopists could agree with these descriptors. So they're hoping to now publish more, lining this up with histology, that this becomes a more standard way of describing lesions for future study. This is one last study that just came out in August of this year from Brazil. It's more of a real-world study where they looked at consecutive screening colonoscopies from July to December, and they split them up a third, LCI or white light or BLI. They were only done in one of the modes. These were majority 50-year-old patients, and more than half were women. And a total of 296 lesions were detected, which is a 75.6% detection rate, which is quite high in 50-year-old women. The LCI detected 84%, white light 70%, and BLI 73%. And then 251 adenomas were detected, which was a 62% ADR, 71% in the LCI mode, 53% W in white light, and 62% in BLI. So the LCI ended up being statistically significantly better at finding adenomas than white light. There was no difference between LCI and BLI or BLI and white light. So the authors concluded that LCI significantly increases detection of adenomas in screening colonoscopies. This is a video that I thought was nice to show by Dr. Meining in Germany of how it looks on our screens when we're doing the Fujiscope. Up here, you can see it shows the light source you're in, BLI. He's showing a tubular adenoma, that it's a nice classification type 2 with visible vessels and slightly thicker than the surrounding mucosa. Here he switched to the LCI mode, you can see. This is how we see it, where our pictures are saved. It shows the orientation of where our instrument will enter when we go to remove it. So it's quite user-friendly. And then this is the same patient. He finds a lesion in the ascending colon, and you can see in the white light mode that it's got a regular surface, a polypoid appearance, and there's a mucus layer. You can already see that there is some central pitting, so you're concerned off the start, but then he'll switch now. You see the BLI mode, and you see in the periphery, there's the nice type 2 classifications with the clear patterns. Here it is in the LCI mode, but in the middle where the pitting is, it's not only depressed, but the pattern is completely lost, and the vessels are not regularly spread. And that's a nice type 3 classification. So now with the central depression, nice type 3, you're worried about submucosal invasion. So because of the characterizations, you can see here, these boxes are filling up because he's using a zoom scope and zooming right in to see the pattern. So because of the light modes, he decides to do a full thickness wall resection instead of a snare resection. And it ends up being a T1 carcinoma with low risk criteria, so no subsequent surgery is required. At the last session, some of the feedback was that they wanted us to talk about our own experience using Fuji. So at St. Joe's, we adopted the Fuji scopes 2 years ago, and we were the first hospital, the only hospital in the GTA to adopt Fuji scopes. There was some hesitancy and concern in the past because the manufacturer was not nearby if we had service issues, but we definitely liked the personnel that we were interacting with. During the demo, we were very impressed with the technology, how the scopes handled, and 2 years in, it still feels brand new when using them. The LCI mode does really work, makes it almost like child's play. It pops. The borders are easier to identify. It makes it easier to decide whether or not a lesion should be attempted to be removed when it's more advanced based on the characterizations. And we're extremely happy with the personnel and the service still. So as Jeff mentioned, I'm also head of an out-of-hospital endoscopy clinic, and our contract there ends in 2023. And so I'm excited about doing the RFP there, that we have the possibility to adopt Fuji scopes potentially. I do believe from my personal experience, it probably almost certainly improves my polyp detection rate. Unfortunately, we do not calculate our own polyp detection and ADRs at the hospital. However, in Ontario, we do get provincial report cards, and I am looking forward to seeing how my rates compare starting from when we began to use the Fujinon scopes. And that's the end of my talk.
That was great, Ian. Thanks so much. Waiting for questions to roll in from the audience, but I'll ask you one first. Are you doing all of your work well in LCI, or do you start with white light and then flip to LCI? What's your current approach?
So I found that I had to learn. I couldn't straight go to LCI mode. I found it difficult for my eyes to adjust at the beginning, but now I consistently enter in white light and withdraw in LCI. And I will toggle frequently back and forth anything that I see that stands out. And I think that probably I take in cumulatively the information from all three light modes, but LCI is definitely my withdraw default mode.
And what do you think the learning curve actually is? Can you speak to that? Because a lot of people sort of like to go with the status quo, but you know, any change in technology requires some sort of learning. What do you think the learning curve was switching between, you know, from Olympus to Fuji?
Well, I was never personally a fan of the light source, the light mode in the Olympus, so I did not actually use it as much. I've also used Pentax, so I used it more in Pentax, and there was a learning curve. So I would say that you should allow yourself at least a good 100 or so scopes of withdrawing in what's most familiar white mode, and then switching to the LCI and BLI when you identify. And I think soon the brain learns pretty quickly how much easier it is to distinguish the LCI from the background. Of course, Mark's talk is different, when you're looking at colitis and so forth. It depends on the reason why you're doing the scope and so forth. But I found that the learning curve, after 100 scopes, you're pretty much more comfortable with drawing LCI than white light.
So that's about a day and a half at St. Joe's, right?
Yeah, pretty much.
Yeah. Mark, you had a question? You raised your hand.
Yep. Thank you. Can you hear me okay?
Yes. Yeah.
Okay, perfect. Which works well for my presentation. Great. Have you noticed in any issues, when you have to lift a polyp, have you noticed any color concerns? You inject you lift the polyp up with some ethylene blue and some saline or whatever you want to use. Have you noticed any color concerns if you're doing it with LCI or BLI, like an obscuring of the margins, perhaps, or anything like that, using these special light modes?
Yeah, I think that's a great point. So actually, that's worth mentioning. So while I use the LCI to screen, once I start to intervene, I actually will switch to white light as my default during the intervention. But then I will toggle back to LCI or BLI to confirm if I'm satisfied that I've gotten the entire lesion and the margins.
Yeah, that's a great question. I do the same thing. I think once, LCI is outstanding for detection. You're going to talk about that too, Mark. But once you start injecting and, you want to see the blue of your injectate, and, a light that makes red things redder is not helpful at picking up the blue. And the epi actually that I put in my injectate will actually make things harder to see. So once you've found your lesion, you've interrogated it with BLI, I'll also turn back to white light. And then after I've removed it, I'm examining the border, I'm examining the defect, I'll go back to BLI to ensure that all your lesion is removed. So that's a great point. If we don't have any, I don't see any questions from the audience. Your talk was obviously unbelievably clear. And everyone is scared to ask you questions because you're so intimidating. So we will, if any come back, we'll keep you on the panel here and we'll come back and ask you some more. So why don't we move on? So Dr. Mark MacMillan is moderated our last session and was very nice to me. So I will probably not return the favor. He is an assistant professor with Dalhousie Medical School and Memorial University and specializes in IBD. So I'm actually very excited to hear his take as an IBDologist on where this technology is, and we can kind of debate back and forth as to where it's most appropriate to use. So Mark, thank you so much for speaking tonight, and we look forward to hearing from you.
I'm just working on the presentation part here. One sec, sure. I'm gonna stop sharing that one and pick a different one.
Ian, I'll ask you one more question while he's pulling it up. Do you think that, I know you said you don't have data from your unit, but do you think that withdrawing in LCI makes you more efficient? Do you think your withdrawal time necessary to achieve an even higher ADR is less?
I think that's a fair point. On the one hand, I think it is when there's no lesions, but I think I'm finding more lesions. So my withdrawal time ends up being longer because I'm pretty sure anecdotally, if you ask most of our endoscopists and nurses, they'll say we're just taking out more than we did before.
Right. Well, I mean, part of that obviously is biased by the fact that we're doing more appropriate colonoscopies in the FIT positive population. So it's hard to sometimes tease those out. But yeah, I guess, you know, also we talked a little bit about this in the AI session, is where is that balance between, like, you know, you want to be finding more of the clinically significant lesions and not necessarily taking out lesions. But, you know, I guess my opinion on that is, if you're, the future is, I think, resect and discard. And so if you're better able to find lesions and you're better able to interrogate those and make an optical diagnosis, be it with AI or LCI and BLI, then your patients are going to be better off, right? We need to balance efficiency and cost and all of that stuff. So yeah, I mean, it's, I guess time will tell, but that's good. Okay, Mark, fire away.
All set, Jeff. Thank you. And I will say, I appreciate the comment. Being an IBD specialist, I'm more of an IBD focused gastroenterologist. I didn't do any extra training, but whether it's a good thing or not, most of my practice ends up being IBD based on where I live. There's a huge amount of IBD in the Atlantic Canada area. So my talk is mostly focused on LCI about IBD management. And I will provide a caveat that I've only been doing this now probably for about the last year to year and a half, using LCI in my withdrawals. And it, as Ian said, it took a lot of experience to get used to that sort of light mode and looking at things. And I've also tried to compare it to chroma as well. And I don't have any data in this presentation about comparing LCI versus chroma. We can talk about that maybe in the question session about, you know, what might be better. Ian spoke about this already, so I won't talk about this slide much. You can just see the way that this light mode does really enhance these lesions much better and allows us to see them much more quickly. So there's not as much data in IBD, specifically UC, compared to what Ian had mentioned, but there are some studies about talking about mucosal healing and assessing these patients during withdrawal. So this was a study which was first seen by me a few years ago, and this is a study in 52 patients for UCs who were enrolled, and they looked at about 190 different areas in the colon with LCI. And they classified the sections either no redness, which is A, B, which is redness with visible vessels, or C, redness without visible vessels at all. And here you can just see a sort of an image representation of how they classify things. So you can see A versus B versus C from top to bottom there. So B being interesting is where you see some vessels still present, and then C being where you've lost most of the vessel pattern. You see mostly just erythema within the colon. And this just goes to compare some of the different light modes in terms of what you see with your Mayo score. So those of us who've done a lot of IBD, we know that we have the subscore for Mayo in terms of Mayo 1, 2, and 3. And there's also, 0, 1, 2, and 3. 0 being most likely mucosal healing. So in those patients, you can see most of the colon was either an LCI of A or B. So pretty much normal, or maybe just a bit of a vascular pattern enhancement. Whereas if you get into a more severe disease, which is a Mayo 2, you're seeing mostly loss of all the vascular pattern and mostly just erythema, which is picked up quite nicely by the LCI-C. And this is a comparison with some of the histological findings. And not a lot of us use the MATS score. In fact, this was the first time I was reading this paper. I've actually heard of MATS, and I may be embarrass myself by saying that, but I actually wasn't someone who was familiar with the MATS score. But what this shows is just that as you get more severe, so obviously a MATS 4 being more severe than a MATS 2, it kind of correlates to what you're seeing in terms of the light score. So if you have a MATS 4, you're more likely to pick up a couple things with the LCI versus a MATS 2, which is more of a benign sort of histological finding. You're mostly going to get an LCI of A grading for those colonic biopsies. So based on what we know, and this is a debate amongst IBD physicians across the country and across the world, really, about mucosal healing, histological healing, and the comparison. So the current thought is that histological healing probably correlates pretty well with mucosal healing and predicts better outcomes in the long term for our patients with IBD. There is some debate about that, and depending on which score you look at. Using LCI, you can use this as a predictor of UC relapse. And for patients in this trial, if you had an LCI of A, you're more likely to remain in remission ongoing versus those who were either classified as a B or a C. So, B and C correlating to that MATS of 2 and 3, you're more likely having a chance of relapsing into the UC. And their thoughts were that perhaps this particular type of classification could be superior to Mayo endoscopic score. I don't think we're quite there yet, but it is a suggestion by the authors. And again, this could be a novel approach for evaluation of colonic mucosa and predictive of some of the outcomes for our UC patients. It was a small study, as most studies in IBD are, and again, limited to a single center, so further evaluation moving forward needs to be done. Here's another trial. This is LCI for evaluation of mucosal inflammation in patients with UC, and you'll see that most of my slides are focused on UC as opposed to Crohn's disease. So here they looked at mucosal healing defined as either a Mayo score of 0 or 1, compared with conventional white imaging, which is what we do mostly now. And they took a look at this and reported the patients who had an MES of 1. They felt that they had a higher risk of relapse than those with 0. And that sort of correlated back to the concept of mucosal healing being predictive of patients being able to stay in remission long term. So this is a pilot study, again, small numbers, 21 UC patients who underwent colonoscopy with UC, looking at endoscopic, radiological, and histological criteria. They were evaluated for treatment response, which included either documentation of mucosal healing with the Mayo score and, of course, with endoscopic activity. MES of 0 or 1 were considered inactive disease, and obviously 2 or 3 were more active. And here you can just see a sort of a representative picture. And I'm not sure if my mouse works, but maybe it does. So you can see this is sort of white light imaging. And we all would agree that there's probably something going on here. And this green box sort of focuses on a lesion that could be somewhat of concern. And the LCI kind of highlights the same area. But what I find with this image is it kind of just takes away some of that extraneous sort of redness and maybe even some of the poor bowel prep. You can sort of see a border here. There's some significant inflammation in this image. And it kind of extends a bit further down here in the lower right-hand corner, more than what I've seen on the white light. You can see here there's some definite border changes, perhaps even some induration and elevation of the tissue here, indicating some ongoing inflammation. So they classified things as either an L, A, or a B based on the color space. So L defines brightness, A defines green component, B defines that yellow-blue component. The color difference between inflammation and non-inflammation was more than twice the difference for LCI with white light. So you see things more clearly using LCI mode. And they theorized that LCI would be more useful than white light to pick up on that inflammatory changes and the diagnosis in UC. So again, their theory was that you would get better images, more brighter images, allowing that lesion in the background to be visualized better than other, specifically with white light, or other systems, including the narrowband imaging or blue laser light imaging, and with the MBI being what I experienced using Olympus prior to my time using Fujiscopes. And they also felt that LCI would be useful not only for detection of inflammation, but also for the characterization of that inflammation. Again, nothing we see is really going to replace that biopsy. You do need that biopsy for the pathological diagnosis, but LCI may help you to identify areas that you need to biopsy perhaps more aggressively to gain better histological information for your decision making moving forward for treatment in patients with UC. Another article, again with LCI, again in UC, you'll notice a trend. A lot of these are coming out of areas in Japan. In this trial, you had 2 endoscopists who were quite experienced using the Mayo endoscopic score, and they used either white light or LCI for each case. The patients that were evaluated were 12, again, small numbers, 10 of which of those 12, so about 80%, had an LCI region that went on to be recognized by the LCI, so it was picked up more than with white light. And here you can see a sort of some representative images again in this trial. So with white light and LCI, and a Mayo score of 0, so relatively healthy bowel versus more of a endoscopic 1. So you can see here, you start to see some inflammation in this image, but when you actually light it up with LCI, you can see there's quite a bit more than you may have actually originally seen as areas of concern during your withdrawal. And you may have just said, okay, well, I see some inflammation here, I'll biopsy here. But in this image here, which is similar to something I did today, you're looking and you say, okay, well, there's actually something going on down here, and I'll do some more imaging, more biopsies down here because it appears there's more inflammation than I originally had thought, because it doesn't look all that active right here. But when you compare it to the LCI lit up image, like Ian said, it just kind of pops. You can just see that inflammation better moving back when you do the withdrawal. And here's a Kaplan-Meier score curve showing relapse-free survival for UC patients with or without using LCI. And you can see for those that did have a positive LCI score, you can see that relapse-free survival is actually less. So we're picking up more active disease using this particular light mode, and letting us know that you should focus your biopsies here more, because you're probably going to pick up some more active disease on histopathology. And if you truly believe that histopathology is the gold standard or the holy grail for remission for these patients, we really should be focusing on this light technique to pick up more areas of inflammation, getting more biopsies, which will then sort of assist us or perhaps even change our decision on management moving forward. Oops, sorry, there we go. So in summary, these images in the study show that LCI will be more useful than white light for diagnosis of inflammatory UC. You're going to pick up more inflammation and perhaps biopsy more in that area. The study itself didn't specifically correlate LCI findings with histological findings, which we'll talk about in an upcoming study. So there was some limitations with that. But again, perhaps this color enhancement would suggest the lack of, or perhaps the presence of, mucosal healing, and the need for consideration of treatment enhancements or changes in our IBD population. So this is another study, again, using a UC for an example. This study did discuss histological findings. So Dr. Colin Bell, which for those who run a line who are IBD interested physicians know that Dr. Colin Bell is quite an expert in the IBD field. So his classification for remission is a Mayo score of 1 or less, and this has been accepted mostly across the field and is used in most of the clinical research trials in terms of for remission for IBD, for UC specifically. So it's the absence of any sort of mucosal friability, and there may be some vascular changes, but nothing too significant. So what this study does is look at LCI and determine if they think LCI correlates with what we get in terms of what we see visually, and then what we get in terms of histopathological findings. So they classified the groups into A, B, or C. So group A is white light, which looks normal endoscopically, and then the LCI also lights up and looks relatively normal. So that's your A and B here. So you can see both of those look relatively benign. Group B was white light negative. So again, it looked normal, and I would argue that maybe, if you're really paying attention, there might be something there. But then if you actually turn on LCI, there's definitely some inflammatory changes here. And you can see the vascular pattern is definitely more enhanced. Excuse me. And then for group C was white light enhanced positive. So obviously something happening. And then when you turn on your LCI, you also have those same images lighting up. And again, quite a diffuse change in the vascular pattern. I would suggest quite a loss of vascular pattern in box number F there. So you're seeing there's quite a loss of that vascular pattern in that patient. So what did it look like? And this screen's a bit blurry, but for a Guillaud score, so that's something that for those of us who do IBD, we're more familiar with either the Guillaud score or the Robarts histological index for IBD histological healing. So for a Guillaud score of 0 or 1, which is a fairly remission sort of state of the biopsies, you can see that about for the patients that have LCI negative or white light negative, that correlates with about 89% of the patients. So it fits fairly well. If you have a Guillaud score of 2 or 3, you're going to see 42% of the LCI positive sites will pick up, but they're still saying white light negative. So your LCI does pick up more of these more histologically advanced patients in terms of inflammation. And their finding was based on their data, show that LCI did significantly correlate with the Guillaud score more than just using white light alone. So the non-relapse rates for patients in group B and C were significantly lower. So though they didn't do as well for those who were classified as group A. So again, white light negative, LCI negative group A did better in terms of remission ongoing than those who were B and C. And you can see the p-value there. The LCI classification may be a predictive indicator for UC relapse based on the Guillaud score. So even mild inflammation detected by LCI was predictive of potential relapse in the future. They also said that group A, so if you have a group A, so again, white light negative, LCI negative, was a valid definition for mucosal healing for ulcerative colitis patients. So, you know, some could theorize, should you even biopsy those patients if you have an LCI negative or a white light negative scope? I would say yes, personally, I still do. But maybe in the future, 5-10 years from now, as time goes on and the data gets better, maybe this will be the new sort of way of doing things and saying, you know what, I don't have to waste my time and do a whole bunch of quadrant biopsies because they have an LCI negative scope. And I'm quite confident that's a mucosal healing situation and a histological healing situation as well. So I know that was quick, but I want to make sure that we left some time for questions. So I'll end there and I will stop my screen sharing. There we go.
I guess I should probably unmute myself. So why don't we go to Ian first? Ian's hand is up.
That's great. Yeah, I know. That was a great talk, Mark. I just actually wanted to ask similar question. Practically, what do you do when you're assessing UC? Are you entering on white light? Are you withdrawing on? It looks like you withdraw on white light and then you switch to LCI when you see inflammation, or are you withdrawing on LCI the whole time?
It honestly depends on the prep for me. I did a scope today where I wanted to withdraw completely on LCI, and she had so much green fluid left that every time I heard LCI, I almost had a seizure. It was so bright in my face with the light. So there is some limitations with that for me personally. So what I'll do is I will say if I have a spectacular prep, mostly in the right and transverse colon, I will do an insertion in white light. I'll do a withdrawal, go back again and turn LCI and go back again on withdrawal. And then the left side, I'm a bit more free to withdrawal just with whatever white light or LCI. I'm more concerned about missing things in that right side colon. I don't think I have a lot of evidence behind what I'm saying, but I find personally, anecdotally, a lot of the low-grade dysplasia I picked up would have been something I would have missed in a right-sided colon evaluation versus left-sided. Left-sided, for some whatever reason, I just find if there's something there, you see it much better even with white light. But in that right side colon, I definitely like to use LCI as long as that patient didn't drink a whole bunch of blue Gatorade and it turns green when it gets in the damn colon, and just makes my eyes go crazy when I try to light that colon up.
And another colored band from the prep. Right.
Yes, exactly.
Mark, one question from the audience is, can you talk a little bit about pseudopolyps and how you approach those in terms of, I guess, detection and evaluation, and how does LCI, BLI help with that?
I personally haven't seen any data on evaluation of pseudopolyps using LCI, and definitely not with BLI. And I have not used BLI ever in a UC patient, unless I found a polyp and I wanted to do a polyp evaluation, obviously, like a traditional adenoma sort of polyp. And I will say that, you know, depending on the patient you have, some of these pseudopolyps, you know, there's thousands of these things. So it's so difficult to evaluate all of those. I find that with a pseudopolyp-filled colon, often the bowel prep can tend to be also not great. So I find the LCI can be limiting in terms of my visualization of the polyps and the mucosa around it. So I often don't. I will say I often don't use LCI if I've got thousands and thousands of pseudopolyps I'm doing withdrawal on. I just say, no, I'm not doing this. I just go back to traditional biopsy and biopsy anything I'm concerned with. And then again, I'll say if you know you're doing your focused biopsy, and if you're doing white light and you see something kind of catches your eye, I'll turn it back on then and look at that. And then, like Ian's talk had mentioned, like if I'm really concerned about the polyp, I'll throw BLI on as well, getting close and say, okay, you know, this has zero pit pattern. This can't be anything else other than an inflammatory polyp, or, well, this looks kind of funny. Just to be safe, I'm going to resect this. And of course, then I end up having to clip a bunch of stuff because these inflammatory polyps end up bleeding like stink most times. So,
yeah, no, those are all good points. I guess, so my question is about is around dysplasia, specifically dysplasia detection in colitis, because that's sort of where I get involved. If someone has, taken random biopsies and they've shown dysplasia, it's usually low grade, because the data, is if there's high grade or multifocal high grade, you could argue that patient should have colectomy. So you get random biopsies that show low grade or multifocal low grade, and then they get sent to me. I do all of these patients in our Fuji room, and I use exclusively LCI for withdrawal, because my experience is that you can detect more lesions, just like sort of we've discussed. What do you make of, I guess, LCI for dysplasia detection? And do you think the difference is it a clinically significant difference in terms of the outcomes? And I won't make you recite all the data, but tell me what you think.
Which is good, because I don't have all the data in my head. So do I think LCI makes a difference for detection of dysplasia? Absolutely. I mean, that's why we're doing this, and this is why why we've done chromo for many years as well. Is because why do we do chroma? Is to pick up these sort of dysplastic-looking abnormal mucosal changes. Right. So yes, I do think it makes a difference. I don't think that LCI is, as I mentioned earlier, I don't think LCI is quite there yet to be able to say, I've got an LCI of, I've got an A, so it's negative. I feel really good about LCI, so therefore I'm going to do 0 biopsies. I still don't think I'm comfortable enough to say that. I still think I will do random biopsies in different quadrants to evaluate things, but I think it's definitely moving forward. You can see those trials started in 2017, 2008, 2019. I think there's a lot more work to be done. And I did ask Rob, our Vantage rep, about comparison. Did he see anything, chromo versus LCI? Was there anything out there? And we're pretty sure some stuff is being done. And if someone's on the call now who does a lot of chromo, please correct me if I'm wrong. But it's being done, but I haven't seen any outcome data yet to say that LCI versus chromo versus white light, like what's the best approach for dysplasia screening. So at this point, I think we still have to fall back on our biopsies, but using LCI as a really good tool to enhance that area where you're somewhat concerned. So for someone like you who gets that referral saying, please see this person for low grade or high grade dysplasia, I found something in the ascending colon, I wasn't comfortable taking it off. I think for you, ideally, that's definitely the place to go and to use it for that.
Right. Yeah, it's interesting. I mean, I guess, so what my practice is, and I guess what the data shows, are not always aligned, but as all of us. But, I think random biopsies are totally useless and a total waste of time. And I know people will argue with me on this one, and I'm not trying to be controversial. I just think it's a joke that we think we're getting a good evaluation of this invisible dysplasia, which I think is a paradox. And, by sampling, 0.5% of the mucosa, I think it's crazy in Barrett's. I think it's crazy in gastric cancer surveillance. And I think it's even crazier in IBD surveillance, where the background mucosa is already altered. So I think having the ability to differentiate that using different wavelengths is game changing. And so I've sort of stopped doing biopsies. Again, a bit controversial, but I think that we need better data to show us that LCI performs, as well as random biopsies. So I think that's sort of the comparison that we need.
I totally agree. That's the point right there, is that, these random biopsies, even if you look at, these biopsies and these studies were done back in the old days when we were like incandescent lights for scopes. This is back before I started GI training, when these studies were done for surveillance. So it's definitely old data. It's just that I'm that somewhat risk adverse person. I'm terrified if I don't have in my dictation that I did some random biopsies. Then, if something does come up, do I get in trouble for that? So I agree with you totally. Like LCI, chromo, whatever, you're going to get better visualization of the mucosa, and you can do more focused biopsy. And that's where I think the money is, as you said, Jeff. That's where the money is. You're doing those focused, dedicated biopsies of those areas. But if I don't take a couple randoms you know, I feel like, am I not really doing my job as an IBD guy doing the withdrawal? And I know it's probably crap. It's probably crap, but that's just me.
No, I get it. I see a lot of the other side, right? It's like people took random biopsies. They're like, you're good, but the patient has like 3 like synchronous cancers, right? They're like, but my biopsies were normal. The doctor said I was fine, right? Like, you know, it obviously has to be coupled with a good look. Yeah, I mean, the next question was, does LCI help target biopsies? I think that you sort of answered that already. The only thing I'll add to what
I think you would agree as well. I mean, that's the whole point with this modality is find the abnormal looking tissue, focus there, biopsy there, or resect if you have to.
Yeah, exactly. So the answer for sure is yes. And then, you know, what I do is I flip to BLI because that's, you know, how we characterize lesions, decide what I think it is. If I'm not sure still, then biopsy. That's where I think AI fits. I'll ask you your other question. Do you see the potential for LCI, BLI coupled with AI to help differentiate pseudopolyps to decide something you want to resect? Good luck.
Sure. Yeah. Sure. I mean, if you turn on AI in a colon with 1,000 pseudopolyps, you're gonna hear bing, 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 just constantly. So it's gonna be a challenge.
Right.
So I guess I'm gonna say AI is a fantastic future for sure. I think a prior talks talked about that, and I think it's amazing. And I think in colon cancer screening, it is a game changer. Pseudopolyps, I don't know for sure because there's usually just so many of them that I think it would just drive you crazy how often it's going to light off. Yeah,
I think like that's a next 2 or 3 generations from now type thing, right? You're talking about being able to detect neoplasia within intestinal metaplasia. You know, if it can do that, then it can probably detect adenomatous polyps within a field of pseudopolyps. So I think it's just a matter of these deep learning systems kind of figuring it out with time. So I think it is. The only thing, what I'll add is the data that I know on is that there are non-inferiority studies looking at electronic or virtual chromoendoscopy compared to dye-based chromoendoscopy. So our modern approach shows that you don't really need to spray chromo. So I haven't sprayed any chromo in the last 5 years because I'm convinced that our you know, optical chromoendoscopy, whatever you want to call it, is equal to dye-based and a lot less messy. So again, that's just my opinion. I'm just a simple endoscopist that, you know, my local IBDologists sometimes don't agree with me, but it's fun to fight over it.
Yeah, I think a chromos, it's an interesting, and I did some training on it and did it for a little while, then stopped using it when I got the Fujiscope, started using LCI and stuff. And it was interesting because one thing it made me stop doing was that one day I forgot to tell the patient about the fact they're going to pee blue the next day. And my secretary got that awful phone call the next morning saying, "What, Dr. MacMillan, what did you do to me? I'm urinating blue." I was like, "Oops, I forgot to tell you. Sorry, bud."
Like, don't worry, that's permanent.
That's okay. Yeah, it's permanent. You're gonna pee like a Smurf for the rest of your life. Sorry about that.
So I don't see any other questions from the audience. So I think you're safe now, Mark.
I just want to say thank you to both of you as well for the questions and moderating, Jeff, obviously, and Ian for an excellent talk. And again, thank you to Vantage for giving us this opportunity to actually get some of this data out there for people to see and experience. And I'm sure we're going to have more of these talks. I know there's a lot of interest, as Ian said, he heard some of the feedback from last session. I think there's be some more questions about Barrett's moving forward and using these light modes for Barrett's detection and surveillance.
Right.
Yeah, I almost wish I had an opportunity to show. That's probably my favorite place to use LCI actually is on the gastros, the esophagus, and the duodenum. So there really are some remarkable images to share. But thank you.
No, that's great. Yeah, thank you both so much for the great talks. I think, you know, even you both are excellent speakers, obviously, but I think the discussion is really interesting too. And, you know, we've all seemed to have similar experiences, albeit with different practices in different parts of the country or the city. So that's great. Yeah, thank you so much to Vantage and Fuji for supporting. You know, I guess my take home from these things is that you got to get these scopes into your hand before you can decide on how you want to outfit your unit. I know for us, having a dedicated Fuji room has been a total game changer. I've said this before. And I get calls all the time from people saying, we're going to RFP. We don't want to go with Fuji because we've used Olympus for 25 years, or we're with Pentax. We just don't want to make a move. And my answer always is, listen, I can tell you what my experience is, but until you have your own experience, you won't be able to appreciate it. I'll send you all the videos you want, but just get it in your hand. So it's just like anything. So hopefully, this series has at least opened people's eyes to the technological advances within Fuji, and just to get the scopes into their hands. So anyways, with that, I'll probably close the session. Thanks again, you guys. It was a real pleasure, and thanks everyone for attending and for your attention. Enjoy your evening.
Thank you.
Cheers.